Welcome back to Dental XP, and we actually have today, sitting right alongside me, the President of the American Academy of Periodontology. I mean, really kind of exciting to have you with us. And more importantly, PD, I think when I look back, you were probably one of the doyens of periodontal plastic procedures. I mean, I look back, you were really right there when we first started doing them, and we had to go and learn it somewhere. You were the man. And as most of you know, most of the articles we refer to are P.D. Miller. This is P.D. Miller. P.D., how did you get actually into periodontal plastic procedure? I mean, initially it's really treating resection defects because we were having inflammatory issues. And then it kind of evolved, didn't it?
It did, and you know, periodontal plastic surgery comes from the discipline of mucogingival surgery.
Right.
And this really had its beginnings probably back in the 1950s when we used to do more frenectomies and vestibular deepenings and things like that. And I guess the first true periodontal plastic surgical procedure was the laterally positioned pedicle flap. But as you know, that had limitations. There was not enough tissue. And then we began to get into free gingival grafts. But at that time, it was felt because of blood supply and various things that you couldn't cover an avascular root. And so when the free gingival graft first came out, it was used as gingival augmentation to prevent further recession. You placed it at the apex of the recession. Right. So somewhere in around 1976, I began to experiment with various techniques to try to see if I could cover roots, and was able to do it. And interestingly enough, going back historically, I was at Southern California at the Bone Symposium that they used to have, they still have at USC, and John Pritchard was there.
What a wonderful
And
man.
so I went up to John Pritchard and I said, and I was having some success with root coverage grafting, and I said, Dr. Pritchard, I said, are you having any success covering roots with a free gingival graft? And he said, no, I'm not. And I said, well, I'm having some success. Well, here I was with one of the titans in periodontics, and I was saying I could do something that he couldn't do. Interestingly enough, he put his arm around my shoulder and began to explain to me why what I was doing couldn't work. And, you know, in the presence of a man like that, I didn't argue with him. And I finally said, well, Dr. Pritchard, I am having some success. He said, well, send me some cases, and he walked off. So I went home and I got a sleeve, you know, the 20 on a page, and I put 5 or 6 cases and I mailed it to him. And he was in Dallas and I was in Memphis. Well, at 8 o'clock one morning he called me up. And they said, Dr. Pritchard wants to talk to you. I said, okay. I went to the phone, you know what he said? Boy, write this up. And I'm not sure I would have written it up, but when a John Pritchard gives you an order like that, I sort of came to attention at the telephone, and lo and behold, I did write it up. And I was just a unknown practitioner in Memphis, Tennessee, with no academic credentials, not associated with the university. So I decided what I would do on this is I would document 100 consecutive cases. For the simple reason, had I been in a university setting, I could have probably done 6 to 10 cases and written it up, but I felt like I had to bowl people over with the numbers.
You did do that?
And interestingly enough, as I began to do this, David, there were certain cases where I could not get root coverage on. But I was doing the technique right, but because the tooth was extruded and the cemento enamel junction was higher, I said, well, wait a minute. I don't have a chance of getting root coverage on these. So out of that developed the classification. And then after I had done about 25 cases, I had 2 cases where I had failures. And so I took those 2 records home one weekend to look at them, and the common denominator is both of them smoked over a pack of cigarettes a day. Now with the connective tissue graft with a bilaminar circulation, you can get away in the smoker, but in the free gingival graft and a deep wide recession, it was much more difficult to do. So that's when I decided that smoking was an integral factor. And I don't know about you, but I've been practicing, you and I have been practicing a long, long time. And this may sound like heresy, I would rather have a poor cleaner that I'm seeing every 3 months as a good cleaner who smokes, because I will lose attachment on smokers, but poor oral hygiene, if I stay on top of them, the tissue looks horrible, but I don't tend to lose attachment. But in smokers, I tend to lose attachment.
You get a gingivitis, but you may not.
But you get, that's right. So in doing that, and interestingly enough, I started this in June. And it took me until November the next year to get 100 sites. So I came back in 2001 and repeated the study. And it took me 6 months because we're doing so much more grafting. Because if you think about it, when this started, the only places we were grafting was in the lower anterior. And now I would say that the lower anteriors are only about 20% of the teeth that I graft. I'm grafting a lot of premolars, molars, and things like that. Now, I analyzed the data of the first study, and the typical patient that I treated was a young adult in their 20s. The vast majority of them were female, and that's true. And the vast majority of the teeth that I treated were the lower anteriors. Then I came back 25 years later, 2001, not quite 25 years later, repeated the study. Now, because
100 cases again.
100 cases, but I didn't write it up or document it. I was doing it for my own satisfaction. Here's some interesting things that came out of that. The average patient that I'm grafting now is a female in her 40s. And because I'm not grafting as many young children, if I see patients over 35, the vast majority of them have some level of missing tooth structure and abrasion. We're taking out an awful lot of restorations now, which I didn't think when we started with the technique that was possible. And I was apprehensive when I first started taking out restorations because some of these with mechanical retention were so deep. And I said, am I going to get a pulp exposure and have a mess on my hands? Knock on wood, I've never had a pulp exposure. And I think the reason is these have been in a long time and you had secondary dentin built behind them. But then you go in on so many of these teeth and you take the restoration out and they've undermined the enamel, and you've got to get rid of that undercut. So one of the complications that we see now of taking out restorations is you get a tooth that is overly short. You can get the excellent root coverage, but rather than say a premolar being 9 millimeters long, it may be 7. Well, you've got the option of leaving it 9 and leaving some defect there. Then the question comes to mind, do you want to place a class 5 restoration in that area? So if you're going to do that and you anticipate it, you need to send the patient back to the restorative dentist, have them reestablish the cemento enamel junction where it should be, and then I will graft to it. And that's a whole lot easier to do before I do the graft because the margin of the restoration is high and dry. If I do the graft, then they got to put the cord in there and all that. So there's been a great evolution.
Now, when you send it back to have the restoration placed, do you have a particular preference for composite versus, say...
I leave that up to the restorative dentist, whichever they prefer.
It doesn't matter.
Doesn't matter to me. And of course, that's one of the beautiful things about coming to the American Academy of Aesthetic Dentistry because this is the one time that I, as a periodontist, get exposed to restorative materials. And I find that very enlightening.
The Academy does do that, doesn't it?
Yes, they do. The cross-fertilization.
It's fabulous. And
Cross-fertilization.
you then actually go and seek some of this information out in greater depth. Petey, it's really great having you, and I appreciate it. And if we can, we're going to send Livio down and come and...
I'd like that.
Get some slides. I mean, some of those things are really classics.
Yes.
And they should be recorded.
Yes, I'd be happy to do that.
We would appreciate it. So.
Good.
Thank you all for visiting with us.